Let's proceed to the next talk on successful global practices and strategies that promoted ethical organ donation lessons learned. May I invite the speaker, Dr. Riadh Fadhil. May I now invite the chairpersons for this session, Dr. Francis Delmonico, Dr. Mehmet Hebral, and Dr. Amresh Krishna. Over to the chairpersons.
Good afternoon. The next topic is successful global practice and strategies that promote ethical organ donations, lesson learned. My co-chair are Professor Francis L. Delmonico and Dr. Mehet Hebral. The speaker is Professor Riadh Fahad, who is a professor of urology and transplant surgery. He is also the director of Qatar Organ Donation Center. He is also associated with Hamad Medical Corporation and Well Cornell College of Medicine at Qatar, and he is also member of WHO Task Force on Organ Donation. As this is a recorded session, I've been told, so please play the session organizers.
Good afternoon, ladies and gentlemen. I would like first to thank the Indian Society of Organ Transplantation for inviting me to be part of this great gathering. I would like to talk about some of the practices and strategies that prompted ethical organ donation worldwide and the lesson learned from it. Organ donation and transplantation are unlike other fields of medicine and surgery. Their success depends on more than mere healthcare infrastructure and clinical expertise. It depends on public participation in organ donation, whether living or deceased. Treating the public as simply passive recipient of policy decisions and call for participation is irrational. They cannot respond immediately to the call to organ donation. The public should participate, will participate, and they will not participate unless they are well informed, fully involved, identify their benefits, feel safe and free, and gradually, with accumulation of experience, develop trust in the system. We should provide them with good health that is accessible to everybody, financially affordable and acceptable by the community, and meet their expectation. We should not start with asking them to organ donation. We should address the different community expectation and address their inequality. And once we address these inequality, then we can claim fairness. Giving them everyone the same, actually is not fair at all. And we will not reach our target, which is the trust of the community. To develop the organ donation and transplantation program, we need to lay the foundation of the ethics and legal system before we start the transplant program. And we should ask ourselves, what is the source of the organ of that program? And we start to work on it before. It's not a matter of bringing the surgeon and the physician, and that's it, we have a transplant. And then promotional messages, national promotional messages could be reciprocity, as in Israel. If you are on the donor registry, you get priority. If the Doha model, which aspire equity, human rights, respect of dignity, freedom, free of financial consideration. The Iranian model, which depends on the religious mission that has political power, and the Spanish model that has a good education system, a robust transplant system, and the opt-out system for the organ donation. The education, we start with preventive medicine. We shouldn't start with talking about gaps between waiting list and transplant. Our countries in the Middle East and Southeast Asia, our patients are not dying because of the lack of organ. They are dying of infections, and they are dying of the organ failure because they don't get access to the dialysis. These sort of things should be addressed ahead of addressing the shortage of organs for the transplant. Then once the people start to feel safe because they are well cared for, prevented from diseases, then they will start to participate in organ donation. And then if we develop tools like ethical committee, donor registry, waiting list, this will help to increase the trust of the community. The campaign. In Qatar, we have well-organized campaign that runs in all the booths in Qatar. where we meet the people, educate them on health, and then if they want to register, they go for donor registry. Our donor registry is about 400, half a million, which is almost 25 to 30% of the adult population of the country. A very good system. Well, is it worth it? Yes, it's a very good investment because it is giving me about 20% of the total number of transplants. So it is worth it to spend your money on the donor registry. And as well, the donor registry will, and on the campaign and the donor registry. And the donor registry will provide you with higher success rate in approaching the families, because when they see that their loved one has is a registered donor, they will accept with a higher rate. In Qatar, 75% of those family approached with the donor registry, with their son has a donor registration, accept. While when there is no donor registration, they do not accept in 75%. So it is increased from 25% approval when there is no registration to 75%. So therefore, I am saying it is very useful and very things to add to your program. Well, they talk about opt-out. Definitely opt-out will increase the donor registration, but it is with one condition, that you ignore the family and you take all the organs, which we don't do. Most of the system, of the program, they don't do it. And they have the same problem. It's the same problem that we have. In the Netherlands, they report the same thing. When the patient has a donor registry, the family will accept higher rate. So the successful opt-out system with a higher rate of deceased donation is when they don't ask the family, which we don't like it. Most of us, we don't like this. In Wales, this is what they have done. This is what they have reported in 2 years after implementation, that the increase in deceased donation that happened after the opt-out in Wales is equal to the increase in other places of UK. So no much increase. The second thing that they always talk about is the incentives. Well, we have tried the incentives. Incentive doesn't increase organ donation. It decays the trust of the people. It will give just the first or second year increase, then it will go down. But when you have a reform, this is it. When we started the reform in 2010, the organ donation started to increase. And this is the same in Korea, the same happened, and in Philippines, the same happens. So people who have a better organ donation and they are still paying the incentive, it is not because of the incentive, because you are good, because you are doing better your job, and because all the world is increasing the organ donation. Now, to increase the donor pool, we have the laparoscopic donor nephrectomy, which definitely increase. It is very good tool. It is very good surgery thing that will reflect a very good. I remember the days when we discharged patient before the donor because he's complaining of his infected wound and big wound and problem. So now it is the safety, the good outcome, the early discharge, the less pain, that is appealing for the people. And it is not only doubled in Europe, in America, they say it's doubled. In Europe, there's this tremendous increase. But I think for us, it was multiple many times. We used to have nothing, now we have more than 100 every year. Now the ABO incompatible, they used to say it is risky and with a little bit hesitation on accepting it as a good model for increasing the incompatible, ABO incompatible live donor kidney transplantation. But these are the statistics. The long-term survival and long-term graft survival is comparable to the ABO compatible. It's the early mortality that is increased a little bit, 99 to 99.7. So this is a minor change, better survival in the first 6 months after IBO incompatibility. But later on, it's all the same. And we have implemented it in Qatar. It is cost effective. It's very good. And when you have a good immunologist to control the system, it's beautiful. It's working. We don't feel the difference. Optimization of the donation system, you have to have a good staff training, you have to have a good policy, you have to have a good leadership, and give the leadership to intensivists. This is very important. It has changed all the aspects. Proper leadership and governance, quality and kidney key performance indices, regular audit, and proper allocation system, waiting list. Using of extended criteria and marginal organs. You know, the number of traumatized donor, a traumatized deceased donor is decreasing. Traumatic death is decreasing. Now we have to go to other causes, including infection, old age, and higher risk donor, and obesity, suboptimal organ function. And we used to do at the beginning of the program, you have to watch, but gradually with the increase of confidence, you go for double kidney, you go for a treatment of whatever in the kidney before you transplant it. So this is use of higher risk organs allowed life-saving of transplant that couldn't otherwise be performed. This is important. Yes, the result is suboptimal, but these people, if they don't have the transplant, they will die on the waiting list. Now, the last is the controlled donation after circulatory determination of death. And we see that it is proliferating all over the world. And in some countries, it is more than the brain death. And all over the world, it's about 22% of the disease donation is from DCD. The DCD is mainly going to the kidney because the liver are still reserved about the using the DCD liver, but kidneys is using is getting the advantage of the DCD more than any other organ. In Canada, it's increased 25%. In UK, it's 40% increase of kidney transplant. The problem with DCD is that you have a higher rate of delayed graft function and delayed graft function, but the long term, 5 years, 1 year is similar. So comparable to the DBD, but the perfusion now, the perfusion has solved the problem. The hypothermic machine perfusion is helping to decrease the delayed graft function. And finally, I would like to attract the attention to this conference report that is issued at the beginning of the year. It's about disease cardiac death, and it is done by a great group led by Professor Francis Delmenico, Beatrice, and Nancy Asha. And the next paper is another paper that came out of a workshop that organized by the Pontifical Academy of Sciences and co-sponsored by the WHO, and it is like a guide for the essential components of the transplant and organ donation system that has to be implemented by the member states all over the world and of the WHO all over the world. And it is very nice read. Both use people, I advise you to read. Thank you so much.
That was a wonderful talk, sir. And I was really intrigued to know that how the creation of a donor registry helped to increase the uh, people coming for donation who were agreeing for donation. So in India, we have seen that there is a gender bias in kidney donation. Most of the donors are female, whereas most of the recipients are male. So is there a similar thing in Middle East, or what is the ratio of female donor to male donor there, sir?
Well, you have asked me about two things. One, about the donor registry and how we arranged it. At the beginning, we have to know that the demography of our country is that we are 25% Qatari, 75% expatriate workers. And most of them are from Middle East and Southeast Asia. Some of the nationality of expatriate nationality are more than the Qatari nationality. So we need to address these people, and we have aspired equity. So we have to provide dialysis, donation, and transplantation for free for all of them. We have to reach out for them and teach them about the prevention of organ failure. And we have to talk with their language, with their religions, and with the same expatriate, their natives. So this is what we have done. We have chosen from our staff, nurses and doctors. In our corporation, Hamad Medical Corporation has 30,000 staff. So we have all the nationality. I have about 30 nationality in my group, which I call them public educator. They pass a course of educating. What is the message that we want to deliver them? And the message is not about organ donation. It's about what does this health system provide to you? How can you protect your kidney? How can you treat your diabetes and hypertension? It's free, and the brochure that we provide is in 6 languages, and the videos that we make is in 6 languages. At the same time, there is no 2 lists, natives and expatriate, all in the same list. One waiting list, the donor list has 105 nationality, and face-to-face, nothing on internet. At the beginning, we were not using the social media because we have made our research and we found only 15% have this smartphone. Now the situation has changed. Everybody has a smartphone, and we have changed our strategy by years. Now we are using the social media more than before, but still we are facing them face to face. And gradually, at the beginning, the first year, we have only 2,000 registrants. Now every day, nowadays, I am getting about 500 to 1,000 registrants. So it is building up of stories of donors, recipients from different nationalities. They come every month and show their story on TV, local TV, and on the local native channels, media, Indian or Nepali media. The embassies have a very good roles. Ambassadors have very good roles. I didn't show so many things. We have meeting with the National Day of India. We have a meeting with the Indian community to celebrate their National Day and to promote healthcare and good healthcare and organ donation. This is how we reached out to everybody. If you want to donate, if you want to get a kidney for your beloved, then you have to register on the donor registry. And this is this sort of reciprocity that is, it doesn't make a condition. We don't make a condition like Israel. They make a condition. If you are not on the donor registry, you will not get a priority. No. If you are living and studying and working in Qatar, you are eligible for everything for free in dialysis, organ donation, and transplantation. And no commercialization, no money at all, no incentives, neither to living nor to... When they see that in the ethical committee, that the man who is brought by his sheikh to donate, and we say, no, we cannot accept this donation, then he will come later on to register as a donor because he developed a trust. He knows that he is protected. We showed the people who received organs from deceased expatriate, because our target is not the native. Our target is the expatriate, because they are the majority. In this country, the minority is upside down. So this is why we succeeded. This is why we succeeded. And because you are living alone as a worker in Qatar, and you need a kidney, and you have your brother who is willing to come to donate, and he is matching and he is healthy, we will cover all the costs. We'll give him the visa and the ticket and the accommodation, and we'll do the operation for him if he is fit and matching, and then he will return home after 1 or 2 months, and that's it. So this has encouraged people to bring their living donor to register as donor. And as for the second question, sorry to take time, but as for the second question, you ask about male to female. Our community is majority male. We are 80 to 20%. So it is not 50-50 like all over the world. It is because most of them are workers. For the Qatari community who are living in Qatar, the families, for the Qatari community, yes, it is the female more than male. For the expatriate community, it's the other way around. It is male more than female for living donation. But they have to go all through the cult committee, which has psychological evaluation, which has social worker evaluation, and there is a lawyer in the committee, and we have a donor advocate. So it is a very good system, and colleagues who have visited me, they like it so much, and we hope that it will, other countries will make some use of some of the strategies that we implemented.
Sorry to interrupt. May I request the chairpersons to wind up the session? We are running short of time.
Yes. The Heart Donation Accord is aligned with DICG and doing a noble work in expanding access to deceased donation and to combat commercial transplant. Thank you, Professor Riadh Fadhil, for joining live and your word of wisdom. Thank you, sir.
Thank you.
So with this, we close the session. Thank you, everybody.
Thank you, Speaker and the chairpersons.